welcome you to this enlightening session. So just to, although you need no introduction, but to our whole team, I just would like to introduce you like Dr. Stephen Fleming. So he is a great name. He's a big name in embryology, and he's been extensively work in so many publication and books. And to his credit, he has trained so many budding embryologists besides the trained embryologists. Today, we are lucky enough to have his few words from him regarding sperm selection criteria for ICSI. And now I welcome you, sir, and over to you. And please.
Okay, thank you. With the presentation, will that come up, or should I just use my own presentation on my computer?
Hello.
With the presentation, does that come up on the screen?
I think we can see the presentation as well. Yeah.
Yeah, and to move on to the next slide, just click on the arrow. Okay, well, thank you very much, Indira, IVF, for inviting me to speak to those in India this afternoon. It's an honor and a privilege for me to do this. It's actually the first webinar that I've given in India. So I hope it all goes well. So what I'm going to speak to you today about is sperm selection criteria for ICSI. And before we get into the details of that, we probably have to consider a few things first of all. First of all, infertility and its treatment. Sounds like some youngsters in the audience there. So infertility and its treatment using ICSI is an important issue in its own right. So we know that male factor occurs in only about 30 to 40% of all infertile couples. And what we suspect is that the selection of sperm for assisted reproduction is critical because it directly influences the male contribution to the embryo. And one of the issues with ICSI, there are a number of issues with ICSI, but one of them is that the in vivo processes of sperm selection are largely absent. So compared to in vivo or with intrauterine insemination or with in vitro fertilization, there are a number of barriers to the sperm in terms of selecting out best quality sperm by the oocyte. Whereas, of course, when we do ICSI, it's all down to the embryologist to decide what he or she thinks is the best quality sperm. And the problem with that is that, in fact, sperm may look quite normal, look quite healthy, but in fact, they carry fragmented DNA, and we know that that can compromise the development of the fertilized oocyte and embryo. So I always say to people, show me the evidence. So what is the evidence for this? Well, there was a very large study reported just last month from Australia, looking at over 14,000 women treated in Victoria from 2009 to 2014. And these were women undergoing their first cycle of treatment. So it's probably the best controlled population that you can have. So there's no previous treatment that these women had been through. And the results were based on that first cycle of egg collection plus any subsequent frozen embryo transfers from that first cycle. And what they were particularly interested in was seeing how ICSI performed compared to IVF in non-male factor infertility. So this is, of course, where you could easily argue, in fact, that ICSI isn't necessary. And what you can see is although the fertilization rate per oocyte inseminated was significantly higher in the ICSI group of patients, you can see that when you look at the fertilization rates per oocyte retrieved, which is probably the better way to compare the two, you can see that when you look at it that way, the fertilization rate per oocyte retrieved is significantly greater with IVF. So that tells us that not only are we not allowing all the eggs that might fertilize to be fertilized when we do ICSI, but we might in fact be compromising the chances of eggs fertilizing as well. But what was more important perhaps is that when they looked at the cumulative pregnancy rates for these two groups of patients, you can see here that the IVF group above, after 1 to 6 treatment cycles, so remember this is the egg collection followed by frozen embryo transfers, and in the panel below, the ICSI patients, again, they're 1 to 6 treatment cycles, egg collection followed by frozen embryo transfer. And here you can see that for each cycle of treatment, there is in fact no significant difference in the cumulative rate between. Indeed, if anything, the cumulative live birth rates are slightly higher with IVF at each stage. Now, this is surprising somewhat because you might expect that if you're treating patients or couples with ICSI, that they're more like good egg quality, more likely to have non-female factors that would otherwise influence the live birth rate. So this begs the question, what is it that we're underachieving with when we do ICSI, and how might we improve the results with ICSI in terms of better selection of the sperm that we use? Now, I like to think in terms of macro and micro sperm preparation. I don't know if anyone else thinks of it this way. But with macro separation, you're separating the sperm from the seminal plasma. And we know that that's a fundamental requirement for intrauterine insemination, in particular because you have to remove prostaglandins that would otherwise be in the seminal plasma if you want to avoid the patient suffering what can be very painful uterine contractions. But it's also necessary for IVF in order to maintain the viability of the sperm. And indeed, it's recommended for ICSI, and I will show you the data that shows why that's the case. Although in some situations in the past, when there's been only maybe one ICSI rig, I know that, for example, you can drop a drop of seminal plasma plus sperm into a large drop of medium overlaid oil and just wait for the sperm to swim out. So that's a very quick way of sperm preparation for ICSI. And indeed, separation of sperm from the seminal plasma is probably quite adequate for the majority of patients where there are not underlying problems with DNA fragmentation, for example. And then there's the issue of how do we separate sperm from testicular cells in those patients with azoospermia. And more important, perhaps, in this respect of this talk today, is that of microsperm preparation. So this is where we're preparing a single sperm or a population of sperm from within the initial sperm prep. So it's a sperm prep that's free of seminal plasma. We still want to go in and more finely, if you like, decide on the population of sperm that we're going to inject into the oocyte. And in this case, this is possibly beneficial to patients, particularly those with repeated implantation failure and those with recurrent pregnancy loss. So going through macro sperm preparation or separation, the simplest way of doing this is simply washing and concentrating a semen sample. So you mix that with sperm preparation media, you centrifuge typically between 3 to 500 G, or if the patient is suffering from cryptozoospermia where there's no obvious sperm apparent, you may have to centrifuge at 1800 G, and you typically do that for around about 5 to 10 minutes, and that would be sufficient to pellet good quality sperm, hopefully. but unfortunately that sperm is pelleted along with immotile and dead sperm and other non-sperm cells, such as leukocytes. And so what you end up with is, yes, you get a high yield of sperm, but unfortunately, the sperm in that sperm pellet is subject to the risk of reactive oxygen species damage from these poor quality sperm or dead sperm and the non-sperm cells. Then another popular method is Swimup. So with this method, you would place your semen sample into a centrifuge tube, layer some sperm preparation or sperm wash medium carefully above that semen sample so as not to disturb it. And then at a 45-degree angle, you would place that tube into an incubator for 60 minutes at 37 degrees C to increase sperm motility and allow the most motile sperm to swim up into the supernatant of the sperm wash medium above the sperm pellet. And then you could carefully aspirate off that supernatant. And yes, it's very easy to perform. It's very cost effective, and you certainly recover a very clean fraction of highly motile sperm. But the bad news, yet again, is that those sperm that may be swimming up into the medium above, they're nevertheless in proximity to, again, these dead sperm, non-sperm cells in the seminal plasma. And any reactive oxygen species that are being produced by those cells are actually being produced at even higher levels because the sample is being held at 37 degrees for 1 hour. Now, the gold standard, therefore, is density gradient centrifugation, where you have a discontinuous layer of silane-coated silica particles, an upper, less concentrated phase, and below that, a lower, more concentrated phase, and you place the semen sample on top of the upper phase, and again you would centrifuge relatively gently, about 300 G for about 15 to 20 minutes. And then you would take out the sperm pellet, which you hopefully have, or at least the bottom of the tube, about quarter to half a mil at the bottom of the tube, and you'd transfer that to a clean tube, and you'd wash that sperm pellet twice with fresh media. Again, you get a usually fairly clean fraction of highly motile sperm. And the good news is that this is particularly effective with lower concentration semen samples. And pretty much you separate the sperm relatively quickly from those reactive oxygen species producing cells that are left in the seminal plasma or the interface between the two phases. So it is more expensive, it is more time consuming, and at least in the old days when we used to use non-commercial products, there was always an increased risk of endotoxins. So for that reason, Percol, for example, which was actually a very good media for doing this, that's no longer recommended for use because of that problem with endotoxins. Now, what about comparing these different preparation methods in terms of the quality of the sperm that they yield? Now, you can see in the graph above, this is the percentage of DNA fragmentation in the sperm prep following those different methods, and that's compared with the fresh semen sample. And you can see that if you do Swimup, density gradient centrifugation, or density gradient centrifugation followed by Swimup, then that results in a significantly lower level of sperm DNA fragmentation. So these three techniques are clearly better than simple sperm washing. However, if you look more closely, and if you look at the table below, and you look at a more sensitive measure, if you like, of the quality of the sperm. So this is looking at those different techniques, but now it's looking at the sperm DNA fragmentation and the sperm motility 24 hours following preparation. Now, you may not think that's relevant because we do an insemination earlier than that, but nevertheless, it is an indirect measure of the quality of the sperm. And here you can see that density gradient centrifugation followed by Swimup gives a significantly lower level of sperm DNA fragmentation in the sperm that are prepared that way, and especially important for IVF, at least in IUI, it results in a significantly higher sperm motility than the other three techniques. Now, others have looked at these two main techniques, the Swimup and density gradient centrifugation, in slightly more sophisticated means. One way to look at cell quality, if you like, is to look at the telomere length in the nucleus. And here you can see that compared to semen samples that have not been processed, density gradient centrifugation results in a highly significant increased sperm telomere length. And then if you look at things like the DNA fragmentation index in that right upper panel, both techniques are equally good at reducing the level of sperm DNA fragmentation. And if you look at the generation of reactive oxygen species in the bottom left graph, measured by formalization, again, both techniques to a similar extent reduce the levels of reactive oxygen species in the prepared sperm sample. And again, progressive motility, both techniques equally preserve sperm motility compared to an unprocessed sample. Now, if we think about the criteria that we're looking for in terms of really good quality sperm, this study has identified a sort of grouping of criteria, if you like. So in this study, they suggest that the very best sperm are motile, morphologically normal, non-acrosome reacted, non-apoptotic spermatozoa. And here they've compared, again, density gradient centrifugation to Swimup in terms of preparation of sperm versus the native or unprocessed semen sample. And here you can see that there's a highly significant higher proportion of these very best quality sperm following density gradient centrifugation versus Swimup. And that difference, if you look at, again, looking at the, if you like, the long-term quality of these sperm after 24 hours, that's maintained, but that is only maintained if you keep the processed sample, the sperm preparation, at room temperature. So there is a tendency among some practitioners to put a prepared semen sample into a 37-degree incubator. And if they're leaving that sample for many hours prior to insemination, then this data suggests that you only see that benefit of density gradient centrifugation if you maintain the sample at room temperature. You can see at 35 degrees C, the difference is lost between the two. Now, what about other more sophisticated methods? This is a method I'm sure you're familiar with in India, magnetic activated cell sorting, or MACS. These employ so-called mini-MACS columns, and these columns have paramagnetic microbeads inside of the column, and conjugated to those microbeads is an exin 5. And an exin 5 will bind to phosphatidylserine, and phosphatidylserine is externalized during the very early stages of apoptosis. So this is a way of removing sperm that are starting to undergo apoptosis from the semen sample as it passes through the column. However, of course, you still have sperm within the seminal plasma that passes through the column, so you're still obliged to do density gradient centrifugation. So the principle of this technique is that those sperm that are starting to undergo apoptosis are more likely to be suffering some form of DNA fragmentation. Now, what about if we look at the clinical data that looks at the efficiency of MAX in terms of sperm preparation. Now, if you look at the upper graph, the upper table, you can see that in terms of per intention to treat, if you and per intervention, if you compare the MAX group on the left-hand columns to the control groups on the right-hand columns, you can see that in terms of implantation rates, pregnancy rates, live birth rates, miscarriage rates, there's actually no significant difference between the two groups. So for all patients, it would appear that using MAX doesn't necessarily give you any advantage over not using it. However, if you look at the table, the lower table, this later study looked at specific populations of patients. Now, in these patients, they were either having ICSI with their partner's eggs, or there was ICSI with the oocyte donors. And they looked at two different groups of men, those with sperm DNA fragmentation at a moderate level between 30 and 50%, and those with severe sperm DNA fragmentation of 50% or more. And they compared using density gradient centrifugation alone to density gradient centrifugation after using MAX to separate out the apoptotic sperm. And here you can see that in the right-hand columns with the more severe cases, you start seeing markedly higher levels of live birth rates following MAX separation of the sperm and lower rates of miscarriage. So it would appear that in some of these subgroups of patients that this approach may be beneficial. Now, other methods have been used, and one that's been popular is to use the phenomenon of the surface charge on the sperm itself. And you can see there's a number of studies that have been performed, either using electrophoretic separation or employing the so-called Zeta Potential, in other words, the negative charge on the external surface of the sperm. And varying outcomes have been reported, some which are not significant and some which are significant. What gives the sperm this negative charge? Well, essentially, during, if you like, it's a bit like the icing on the cake, the very last part of spermatogenesis during epididymal transit, there's a sialoglycoprotein called GB20 that is highly negatively charged, and that is anchored to the sperm plasma lemma via glycosyl phosphatidyl inositol, and it forms part of the sperm glycocalyx. And this negative charge, or this Zeta potential, has been associated with normal sperm morphology, maturity, and fertility. In terms of a simple method, this is simply the so-called employing the Zeta potential. You can take a plastic centrifuge tube and you can rotate that tube in a plastic glove, and a bit like rubbing a balloon on your jumper, it will impart a positive charge on the outside of the centrifuge tube, such that any negatively charged sperm will bind to the wall of the tube, and then you can tip out the remaining contents of the not so negatively charged sperm, or sperm that don't possess a negative charge, and then you can wash off the bound sperm from the inside of the centrifuge tube, and that will produce your sperm population of highly negatively charged sperm. Now, a more sophisticated method is to use electrophoresis, and here you can see an expanded view of a separation cartridge where you have a separation membrane separating the loading chamber and the, if you like, the sperm prep chamber. And so the large cells can't get through this separation membrane, but the normal size cells with a negative charge are drawn towards the positive electrode by virtue of that negative charge. And this technique is very rapid. You can separate sperm within 5 minutes, and it does produce a population of sperm with low levels of DNA fragmentation. And in fact, there was a study that was reported a couple of years ago. You can see in this bottom graph here, they compared how what percentages of negatively and positively charged sperm couples had, or the male partner had, in terms of whether they achieved a pregnancy or not. And you can see that on the left-hand histograms, the pregnant couples, they had significantly higher levels of negatively charged sperm and significantly lower levels of positively charged sperm compared to the non-pregnant couples. Another method which has received a fair bit of attention in the literature just recently is that of using microfluidics. So one method is simply to have a periodic array for trapping and isolating sperm. So you can see in plate B, the actual device itself, you can see there's a small loading chamber and a large separation or preparation chamber. And after 10 minutes, sperm that's managed to swim through this periodic array of barriers, they show a 5-fold improvement in sperm morphology, a 3-fold increase in sperm nuclear maturity, and a 2 to 4-fold enhancement of sperm DNA integrity. And some of the latest studies are suggesting that this method is even more effective than density gradient centrifugation. So there are a number of methods that are available to us for maybe better selecting the best quality sperm from semen samples. In some situations, however, semen is not deposited outside of the body. It instead ends up in the bladder, so-called retrograde ejaculates. And in those situations, we need to try and recover the sperm in as good quality as possible. And this, again, is particularly important for ICSI because, of course, although if you do recover the sperm in good enough quality, you can do IVF, but it probably takes a brave embryologist to do that. So most of these patients do end up having ICSI. And many years ago, there was the so-called Liverpool solution from the unit in Liverpool in the UK, where they got these unfortunate men to drink various volumes of a sodium bicarbonate solution and to void the bladder and then drink more solution and then ejaculate and void the mixture from the bladder. And here you can see in these bottom graphs that by drinking this sodium bicarbonate, it brings the osmolarity of the urine in the bladder down to normal osmolar levels, and it also raises the pH up to a normal pH above the acidic pH levels that would otherwise normally kill the sperm. But you still have to be quick in terms of preparing the sperm sample, because you can see that with time, sperm motility does drop off. And then, of course, we're often faced with hazy spermia where we have to surgically recover sperm. And there are various methods that I'm sure you're familiar with here. And there are various methods for preparing the sperm from these samples. Typically, most people use mechanical dissociation, some enzymatic dissociation, and some combine that with lysis of erythrocytes. But a particularly interesting method is in vitro culture. So if you compare mechanical versus enzymatic preparation, you can see that if you look at fresh tissues, cryopreserved tissues, or cryopreserved tissues where sperm have undergone meiotic arrest, you can see that in the upper graphs, yes, you do get a higher recovery of sperm using mechanical dissociation. But if you look in the bottom graphs, you can see that you clearly end up with a higher proportion of viable cells following enzymatic dissociation. So it's clearly a gentler procedure. You might end up with hopefully mature sperm, but you can also end up with round spermatids, which are just slightly smaller than erythrocytes, elongated spermatids that look a bit like an ice cream cone, and elongated spermatids, which haven't detached from the Sertoli cells. And if you compare enzymatic and mechanical dissociation of frozen and cryopreserved tissues, they all, I mean, this is going back a while, 2002 now. At that time, those pregnancy rates were pretty good and they all were comparable. But you can see there's a big difference between whether you're using motile sperm, immotile sperm, elongated spermatids. You get a progressive decline in pregnancy rates. So the motility of the sperm from these testicular samples is all important. So how can we improve that? Well, we can allow sperm to swim out from, if you like, a pool or a lake of media where the sperm suspension, disaggregated sperm suspension has been placed. We can increase the effective surface area by having strips of media and dividing that sperm prep into those 4 different strips. We can prolong the incubation at 37 degrees to try and encourage sperm motility. And we can use chemical stimulation of the sperm. Now, the most well-known one, of course, is pentoxyphyllene, which you can see there labeled C. But essentially, these they're all caffeine derivatives. They all inhibit phosphodiesterase, and phosphodiesterase normally degrades cyclic AMP, breaks down cyclic AMP. And it's the high levels of cyclic AMP that stimulate sperm motility. So if you can maintain a high level of cyclic AMP, you can hopefully pick out a motile sperm. But you need to be careful when using these stimulants, because if you use them at a high concentration, you get a very rapid effect with a quick burnout of sperm motility. So some people use them at a 5 to 10-fold lower concentration to allow a greater period of time during which sperm can appear motile. What I particularly like is this approach of Mitch Shoes. They've in fact been doing this for many years, but only published their data a couple of years ago. And you can see that what they've done is that rather than relying on the motility of their testicular aspirates at 0 hours, and you can see different grades of sperm motility here, from grade 1 up to grade 4 in the yellow, which are the most motile sperm. What they've done is that they've in vitro cultured these testicular aspirates for 1, 2, 3, 4, 5 days. And up to 5 days, you can see there's a progressive increase in sperm motility. So they can either plan this 5 days earlier than they do the egg collection in the ICSI, or indeed they can simply cryopreserve those samples after 5 days of in vitro culture. This is at 30 degrees, by the way. And then with the knowledge that if they then thaw those samples, they have more likelihood of finding motile sperm. So what about optimizing and selecting the sperm preps that we end up with by whichever method we choose? There are various methods that have been proposed, such as avoiding toxins, using oral antioxidants to reduce the effective reactive oxygen species. Density gradient centrifugation, the gold standard, that's actually very effective at bringing down the levels of reactive oxygen species and DNA fragmentation. And frequented ejaculation has been proposed as a way of clearing out the sperm that have been hanging around in the epididymis that are going to be of poorer quality, and ensuring that what you actually use is sperm that's been recently produced and therefore of higher quality. There are essentially two sperm preparation isolation approaches that have been trialed to see whether we can optimize sperm selection for ICSI. One is motile sperm organelle morphology examination, or MSOM, and the other is utilizing the ability of sperm to bind to hyaluronan. And if you like, that's an indirect assay of the sperm maturity. Now, the Cochrane reviews, the systematic reviews, we regard as the highest grade evidence. And the Cochrane review of the randomized controlled trials that had used IMSI showed that those results did not support its clinical use. They found there was no evidence of benefit in terms of live birth rate or a reduction in miscarriage, and that what evidence there was that IMSI improved the clinical pregnancy rates was of very low quality. Now, again this year, one of the main proponents of MSOM and IMSI, so intracytoplasmic morphologically sperm injection, produced this publication, which said essentially that criteria were probably not that accurate, that in fact it wasn't the number of or size of vacuoles that was important, it's in fact their location and their depth. So those vacuoles that are present within the nucleus and the equatorial segment and deep-lying vacuoles, they are related, those sperm are related. When you look at their DNA, they have a very high copy number variation, and therefore very low genomic stability. So the outcome of this particular report suggests that, in fact, previous studies may not have been as clearly conducted as they may be now. So it'll be interesting to see whether any future studies come up with any more convincing data that IMSI is better than ICSI. Now, moving on to the binding of sperm to hyaluronan, we know that hyaluronan is present within the extracellular matrix or the cumulus matrix surrounding the oocyte within the zona pellucida, and sperm that have progressed through spermatogenesis and are fully mature have developed receptors for hyaluronan and have the ability to bind to it. And in fact, they probably use these receptors in terms of navigating their way through the cumulus matrix and binding, initially at least, to the zona pellucida. And it's been shown that the ability of sperm to bind to hyaluronan is correlated with lower rates of aneuploidy within the chromosomes, lower rates of DNA fragmentation, increased chromatin integrity, and better sperm morphology. And you can see that, in fact, if you compare different fractions of sperm preparations from density gradient centrifugation, you can see that straight away those in the lower density fraction, sperm that have migrated the furthest through the gradient, they clearly have the highest binding ability to hyaluronan. So yes, density gradient centrifugation is certainly a good way to separate out these sperm that are the most mature. And there are various methods now that we can use to quantify the degree of binding. So we have the hyaluronan binding assay, which is a slide coated with hyaluronan. We have the physiological ICSI dish or pixie dish that has drops of hyaluronan that can be rehydrated and will bind sperm. And we also have sperm slow, which is hyaluronan in solution. It will act like a wall, so the sperm swimming along, they hit the hyaluronan and they're stopped dead in their tracks. How effective is PIXI? Well, you can see this study here where you can see the drop of hyaluronan in that circular section of the diagram. And here what has been done is that the sperm has been stained with acridin orange, and that undergoes a metachromatic shift in color from green when there's native double-stranded DNA to red when there's single-stranded fragmented DNA. And you can see just by glancing at that image that virtually all the sperm within the drop of hyaluronan are green stained sperm. Whereas you look at the sperm outside of that drop and you can see a mixture of red and green sperm. And in fact, when you look at the data in that table, you can see there's over 99% of the sperm that bind to the hyaluronan have native double-stranded DNA, whereas outside of that drop, there's about 45 to 50, so only 56% of the sperm outside of the drop have native double-stranded DNA. So it gives you some idea of the relative ability of hyaluronan to pick out these native double-stranded DNA-containing sperm. Now, if you look at the clinical efficiency of PIXI, again, it shows its benefit not so much in patients as a whole. So if you look at those upper histograms where it's comparing in the blue the control groups, in the yellow the PIXI group, and you can see that there's not a great deal of difference in terms of the implantation rates and the clinical pregnancy rates between the two, although there is a trend towards higher clinical pregnancy rates and implantation rates when the percentage of binding to hyaluronan in those samples was less than 65% in those columns on the right-hand side. Where it becomes significant is if you look at those bottom histograms, and this is where you can see that if you look at the pregnancy loss in these situations where you either look at the initial or the final binding of sperm to hyaluronan, you can see that there's a significantly much higher pregnancy loss in the absence of PIXI compared to PIXI, where the pregnancy loss rates are extremely low, or in fact in the right histogram 0. However, there has been a Cochrane systematic review of the randomized controlled trials that have been performed looking at PIXI and sperm slow, and they concluded that the evidence was insufficient to determine whether hyaluronan binding improves live birth rates, pregnancy outcomes. So remember, we're not talking about pregnancy loss here, I suppose, so much, but more live birth rates. And also, evidence was insufficient to show whether PIXI or sperm slow was one was better than the other. But the very latest study, which will be published hopefully later this year, which was a multi-center study looking at hyaluronan binding of sperm, so looking at PIXI versus ICSI. And here again, although there was no significant difference in live birth rates before and after 37 weeks gestation, you can see that there was a highly significant lower miscarriage rate when PIXI was employed compared to ICSI. And for the patients, that's an extremely important benefit. So in summary, what can I tell you about the approach to improving the criteria for sperm selection for ICSI? Well, certainly reduce the bench time. Longer you allow semen samples to sit out on the bench, the greater will be the lipid peroxidation due to reactive oxygen species, the greater lipid peroxidation of the sperm, and consequently the greater the DNA fragmentation within those sperm. Avoid elevated temperature at all times. Every time you put a semen sample, whether it's before or after preparation into an incubator. Not so much the problem after preparation, but particularly before preparation into a 37 degrees centigrade environment, you will simply elevate reactive oxygen species. Certainly, try in vitro culture of testicular tissue. I think that's a huge benefit. Usually, one of the problems we have is finding motile sperm from testicular aspirates. And if you have patients that have suffered recurrent miscarriage, and perhaps those patients that have experienced repeated implantation failure, certainly consider using Pixie or Sperm Slow. Thank you very much. I hope that was of some benefit, and look forward to answering any questions that you may have.
Thanks, Dr. Fleming, for such an informative session. I hope most of the questions must have been answered in this such a wonderful session. Now I would request all our embryologists, the session is open for the question answer round. So if you have any doubt, any questions still which you need to be answered, you can put that in the chat.